Welcome to our webinar, The Power of Social Determinants in Proactive Population Health Management. Thank you so much for joining us today. The interest in this webinar has been exceptional, with more than 400 of you joining us today. Over the past 16 years, I2I has been a partner of choice, supporting healthcare organizations who are striving for greater health equity among your patient populations. Integrating social and environmental needs into a cohesive population health strategy and model of care delivery is of utmost importance for all of you. For a community health center providing care for the at-risk and underserved communities, or a practice who needs to coordinate services across providers, or even a health plan with incentives to help members address their broader needs. As you may know, social determinants can be as meaningful as clinical information in managing patients. Today, I'm pleased to be here with two experts who have been in the trenches studying data to identify how social determinants play a big role in health outcomes, Chris Espersen and Sonia Tucker. Chris Espersen works with many health organizations locally and nationally, providing technical assistance and delivering powerful presentations around new initiatives, data governance, patient engagement, and social determinants of health. As a former quality director at a large federally qualified health center, she advocates for the use of data in all decisions and promotes the importance of making data accessible and engaging to both staff and patients. She has served as the president of the Midwest Clinicians Network, faculty member of the National Patient Safety and Clinical Pharmacy Services Collaborative, and serves on multiple leadership and healthcare committees in Iowa. Sonia Tucker, a medical doctor, honed her population health management skills working with indigenous populations in rural Venezuela, where the value of preventive care is considerable. She continued her career focused on caring for underserved populations in North America, Central America, and the Caribbean with a variety of global medical organizations. In 2013, Sonia joined La Maestra Community Health Centers in San Diego, California as the Director of Quality Improvement. At La Maestra, Sonia has taken a leadership role in incorporating social determinants into the center's population health management strategy and driving successful population health initiatives that break down the barriers to care for San Diego's at-risk population. Before we begin, please note that today's webinar is being recorded and will be made available for download after today, so just check your email for more information on that recording. We will take your questions at the end of the webinar, but you are welcome to submit your questions through the GoToMeeting panel on your screen. Our first presenter will be Chris Espersen. She will be providing you with an orientation to social determinants of health, what they are, and how they affect patient care. So go ahead, Chris.
Thank you so much, Nancy. I'm thrilled to be with you to talk about this important issue today. So social determinants of health are those factors and environments people are born and grow into. They involve where individuals live, work, worship, and play. And they all come together in ways to affect health. There are many, many different frameworks you can consider, but they all have similar themes. Healthy People 2020 has an organizing framework that highlights 5 key areas of social determinants of health. The 5 areas are economic stability, education, social and community context, health and health care, and a person's neighborhood and built environment. So many of these areas are interrelated and have compounding effects. You can imagine the effect of poverty on health as it impacts access to care. It affects the ability to pay for medications, healthy food, and healthy lifestyle choices. Forget the price of a gym membership. It might not even be safe to walk outside. Sidewalks may be in poor condition, or maybe there aren't sidewalks at all in the neighborhood. Violence may prevent outside activity as well. Housing, when available, can present dangers such as exposure to lead or infestation, and violence may be present not only in an individual's neighborhood, but in their home if they experience intimate partner violence or child abuse. Education affects health literacy and health knowledge. And social support not only impacts resiliency, but sometimes it can be harmful, as social networks can reinforce unhealthy behaviors such as smoking and drinking. So if a person can get beyond all of these barriers, access to care then comes into question. Does the person have insurance, and do they have a way to get to their appointment? If they do, does the provider speak the same language that they speak? And even those aspects of a person that cannot be changed, such as gender, race, and ethnicity, can have an impact on a person's health-related quality of life due to discrimination, stigma, and genetics. So think of a time where you or a loved one had difficulties with healthcare. Perhaps you had a bad side effect from medication. Maybe a physician or staff member was rude or didn't answer your questions. Maybe you didn't understand your hospital discharge instructions. I know personally I have struggled with that before. Now compound those barriers with not speaking the language your healthcare provider speaks, not having transportation to your appointments, or living in a house with no electricity, with unsafe conditions, or having no house at all. The Commonwealth Fund discussed 70 studies that found poverty and lack of employment led to higher hospital readmission rates. But this is only one negative consequence of social determinants of health. Social determinants affect health in many significant ways. Housing plays a big part in burden of disease. For example, one study found that poor housing can lead to increased rates of respiratory conditions and lead poisoning. People with inadequate nutrition are 20% more likely to self-report hypertension and 30% more likely to report hyperlipidemia. This shouldn't be surprising at all if you think about the high prices of healthy food compared to the relatively lower prices of fatty, salty, and highly processed foods. Infectious disease disproportionately affects individuals based on race and gender, as do other chronic and hereditary diseases. Education also plays a major role in health, as those with higher education live longer lives. And as a country with the highest expenditures with only mediocre health outcomes, cost is of course a high priority issue. Many of the top conditions associated with high spending are affected by adverse social determinants. These reasons and many more are why CMS state innovation models and Medicaid payment reforms are highly interested in interventions that involve social determinants of health. And that's probably why you are all on the webinar today. So being able to proactively address all of these factors is vital for the healthcare system. As a practice, we receive many opportunity lists from insurers and government agencies based on claims data. We also generated our own list from eye to eye based on clinical information to proactively manage patients' health and increase our quality scores. You may have generated similar lists in your roles as well. We have learned a number of things from these lists. One thing we learned is that claims data are not timely, but they can supplement what we have in our EMR. We also found that the list probably will annoy clinicians unless they're introduced properly. And while they are useful information, these lists are a guide and not the rule of law. In order to ensure patients get appropriate care, we need to supplement these reminders with additional information to tailor care to the patient's needs. For the patient who speaks Spanish or another language, we need to ensure that we have interpreters available or other resources to effectively communicate with the patient. And only then can we educate on appropriate emergency department use if it's being utilized as a source of care for the primary care. For the patient who was evicted, perhaps wrongly, from their house, we need to address their more immediate need of housing by involving a medical legal partner or arrange for temporary shelter before we counsel on the need for colorectal screening. And the control of her diabetes may be secondary to the safety of her children when the patient is confronted by intimate partner violence. The care team needs to help with a safety plan before using motivational interviewing to advise on medication adherence or diet and physical activity counseling. Our huddle list and eye to eye were adapted to make sure that all of these elements, patient language, housing status, and presence of domestic violence, among other things, are visible to the care team every single day. Having these data readily accessible are key to proactively impacting our patients' health and lives in positive ways. There are many local solutions to getting services that have resulted in a number of great outcomes. In New York City, the Medical Legal Partnership helped produce a 91% decrease in hospitalizations and emergency room visits due to resolution of legal issues in housing services. Thanks to Tulgawandi, Camden, New Jersey has been a frequently cited community in regards to addressing patient complexity. The community's coalition and care management program has seen monthly hospital charges from the community's highest complexity patients drop by 56%. The Nursing Family Partnership Program provides home visits to high-risk families, and rigorous evaluation has seen many benefits of the program across the country, including a $17,000 return to society for each family on the program. In Seattle, children with asthma were visited by community health workers, and the evaluation of this project saw a potential savings of $334 in urgent care costs alone per child. And finally, even when you cannot directly measure the return on investment in connecting patients to the right resources to address social determinants of health, there are other ways to see your impact. We had one patient who was worried about her son, as he had recently tried to commit suicide. As a mother, there was no way she could focus on her own health, and her recent relapse to smoking soothed her. Her pain and anguish were written all over her face. It would have been inappropriate to address her chronic disease or unhealthy habits. She and her son needed help. Our team huddled on her needs and made sure that her son got the counseling and support he needed. After they were out of harm's way, the trust, respect, and compassion helped establish a relationship, and only then did our team start to work on her health goals. Today, not only is she tobacco-free, 30 pounds lighter, and in control of her diabetes, but her relief, joy, and gratitude show in her smile. We have countless stories like this, and whether it is appropriate language resources for patients who don't speak English, to arranging for transportation to get a patient to their colorectal screening, being able to identify, address, and follow up on these issues is priceless. Now I will pass it back to Nancy to introduce Sonia, who will tell you about the wonderful work her clinic is doing with Eye to Eye to identify and address the social determinants of health.
Great. Thank you so much. That was really great information, Chris. Our next presenter is Sonia Tucker. Sonia is going to share about their innovative model at La Maestra called the Circle of Care, which incorporates services and programs that not only address physical health, but also behavioral, cultural, environmental, and other barriers to health and well-being. She will also be sharing some examples of how her organization uses population data in their daily work to identify barriers and create unique programs to address social concerns. So now I'm pleased to turn the presentation over to Sonia. Go ahead, Sonia.
Hi, Nancy. Thank you so much for having me. This is very exciting. Good morning, everyone that is here on the West Coast, and good afternoon for the ones that are in the East Coast. My name is Sonia Tucker, and I am the Quality Improvement Director at La Maestra Community Health Center in Southern California. To start, I wanted just to tell you a little bit about La Maestra, who we are. We are a federally qualified health center located in the heart of San Diego, California. But contrary to the majority of the community clinics, we did not start as a health center. We in fact started as a social services. In 1986, La Maestra Amnesty Center opened as a nonprofit citizen center and education facility for immigrants and refugees here in San Diego. They were offering services to help them gain citizenship. Based on a focus group with its clients, La Maestra Amnesty Center started realizing that they needed to open a clinic. And in 1990, La Maestra Amnesty Center opened what is called today La Maestra Family Clinic to meet the medical needs of those immigrants, refugees, and low-income residents. Soon, the clinic developed into an independent nonprofit organization that absorbed many of the social services programs that the Amnesty Center had started. So we immediately changed to what we are known nowadays as La Maestra Community Health Center, or better known here in San Diego as just simply La Maestra. La Maestra founders, they knew that in order to achieve the overall well-being, the social determinants of health had to be part of the clinic's mission and strategic planning. And that's why our mission reads what you guys are seeing, to provide quality health care and education, improve the overall well-being of the family, bringing the underserved, ethnically diverse community into the mainstream of society through a caring, effective, culturally and linguistically competent manner, respecting the dignity of our patients. And we take this to the heart, and we practice this every single day. Some facts about La Maestra. We're very unique for many reasons, but one of the reasons that we are most unique about is how diverse our population is. According to data from 2014, La Maestra spoke more than 70% of the patients at La Maestra wanted to speak other language different than English. Because of this, we decided that the staff should come from the cultural backgrounds that we were serving our patients in to ensure cultural and linguistical competency for them. As we see, we speak more than 28 languages and dialects, and they're all spoken by the more than 500 employees that we have here at La Maestra. Something that we have done is we have created what we call medically trained cultural liaison. These people usually provide valuable ongoing support, education to the local residents, patients at La Maestra. They are the ones that help us identify new needs and also communicate to the patients. This is what we are calling offering two-way communications. We have been identified by statistical data some clinical barriers to care. And some of these clinical barriers to care we can define into non-clinical, clinical, and non-clinical. As you can see, we have health-related issues like everybody in any other community health center could have, chronic conditions like diabetes, hypertension, low cancer screening rates. And something that is very important to us is hepatitis B and C. Why am I saying important to us? Because this is definitely a social determinant of health. If you remember, I'm saying that we speak 28 different languages and dialects. We come from different countries. A lot of our population comes from Southeast Africa and Southeast Asia, which, as we very well known, has been considered as a high endemic area for hepatitis infections. Other issues that we encounter are mental and behavioral health conditions, such as cultural diversity issues, domestic violence, human trafficking, isolation, and PTSD. Some social determinants of health that we encounter as barriers are linguistical and cultural barriers, lack of health literacy, misunderstanding of the health coverage programs, which I think, even us, sometimes we misunderstand those coverage, lack of transportation, managed care defaults, and being underinsured or uninsured. As Chris was explaining the different social determinants of health, I wanted to bring a little bit of an idea. The social determinants of health is something really big, and we would love to be able to address every single one of them, but we're doing our best, the best that we can with what we have. We have developed new programs that hopefully will help us and other organizations out there to also bring the best outcomes that we can. So in the effort to improve health in the United States, we have traditionally looked at the healthcare system as the key driver of the health and the health outcomes. The Affordable Care Act increased opportunities to improve health by expanding access to the health coverage and supporting reform to the healthcare delivery system. While increasing access to healthcare and transforming the healthcare delivery system are important, research has demonstrated that improving the population health and achieving a health equity also will require a broader approach, which is trying to overcome the social, or trying to address the social determinants of health. So we know that the poverty limits access to poverty limits access to health, to good healthy foods, to safe neighborhoods, that more education is indicator of better health. We know all that. But how do we approach that? What do we do? So here at La Maestra, we have a unique approach to leverage the social determinants of health and has been very successful. La Maestra's mission is, as I said, to provide the quality health care and education to improve the overall well-being of the family, bringing the underserved, ethnically diverse community into the mainstream of society through the caring, effective, culturally and linguistically competent manner, respecting the dignity of patients. For that purpose, the organization has used what we call La Maestra Circle of Care model to put social determinants of health directly into its way of working. The Circle of Care is a holistic solution-based enabling services and outreach, social services, and integrated social determinants of health efforts, enabling all the services for our patients. Every staff at La Maestra knows exactly the Circle of Care. Everybody, from the receptionist to the physician, uses the Circle of Care approach to identify what the needs of our patients are, to work as a team to assess the patient's needs, and to guide the patients towards the treatment, education, training, and ultimately the self-sufficiency that we are looking for. An internal quality assurance evaluation measures outcomes that we have with this particular holistic approach that we have. And it has shown that the model that we have used is successful, that improves the overall well-being of the patients. The idea for programs originates at all levels in the organizations. The projects are driven by La Maestra strategic planning and the needs of the communities, which is very important. As we can see, what do we need in order to address all these social determinants of health? Because we know they are there, but now what do we need? So in order for us to improve population health, we have to have, as we see here, data warehouse and analytics that allows you to build a scale analytic approach to a systematically integrated and make sense of the data that we have. Applying advanced analytics to organize and measure clinical outcomes, identifying and solving the real problems, helping us to focus on the areas of the great opportunities in terms of quality of care improvement, cost reduction, and revenue enhancement. It's very important that this data warehouse and analytics will be something easy to use. It's something that anybody can use, where that data is available to our patients, to our providers, and to the general staff. Once we have that, we also have to be knowledgeable about what clinical best practice we have, what has been proven to work, in order to improve the care and reduce the cost. And also, once we have all these analyzed, we have to make sure that once the population health management group is able to efficiently collect and use the data and prioritize that data to guide improvement and satisfaction and reduce the cost, we're able to maintain. We're able to form this organizational way to maintain those changes. Plenty of things are making tackling this population health management a little bit difficult. The proper collection and the use of the data is the central of those issues. Managing the pay-for-value reform era has left healthcare organizations struggling to compile lots and huge amount of data, while the electronic health records that a lot of us use give us raw data. Making use of that data is very, very important. Make it accessible and make it user-friendly. And of course, for us to be able to report on the outcomes of each one of those programs that we have makes it very, very important. So this is how I usually start my morning here at La Maestra, with the population health management. This is what we do. The first thing, we get into the quality improvement room and we open our population health management tool to make sure that we are able to visualize the general performance of the organization, always keeping in mind how we can better serve our patients. Each person in the organization can customize what they see per department and what they're interested in seeing. We see different graphics that speak to only them and what their focus is. For us in QI department, it's very important to see how these partners with the social determinants of health initiatives that we have and how these social determinants of health have been addressed. I particularly dig into the data. I love to run my quality reports, as you can see right here. My quality reports speak to me. Within this quality report, I'm able to see the clinical outcomes reveal and exactly where can I see those barriers and how I can assess them. The social determinants of health and how we can assess the social determinants of health and how we can tackle them. Doing so, we have been able to increase, and let me just show you a little bit how our report looks like. So these are different reports, one of the clinical indicators that we run. Doing this and running the reports and looking into the data, analyzing and digging into the data, we have been able to identify places where we needed to increase. Out of those places, we have colorectal cancer screening, as I mentioned before, is one of the many barriers that we have for many reasons, because our patients maybe have misunderstanding of what a screening is or cultural beliefs that they have. So for that, what we decided last year when we saw that our colorectal cancer screening was at 30%, we made an action plan where we make sure to use what we have, or cultural liaison, or patient navigators, that is talk our patients' language, because we realized that the ones that were not getting the screening done were the patients that did not speak English as a first language. We use our cultural liaison in order to have them to speak to the population that they felt identified with. And with that, we were able to increase our colorectal cancer screening from 32% to 51% at the end of 2015. The same thing happened with depression screening. A lot of the stigma on depression screening, especially coming from, for instance, from Latinos. They don't want to get screened because they said, I'm now depressed. And they don't understand what the screening is for. Once we use a cultural liaison, we realized that were the Latinos that were not getting screened because they didn't answer the question. And we explained why it was important. The depression screening for that population went from 18% to 45%. Other population analytic reports that we run here at La Maestra are directly associated with initiatives that we have. We're part of the Million Heart Initiative, where we're trying to make sure that we overcome the barrier that a lot of our patients don't understand how to control their hypertension or even what hypertension is, because that takes us back to another social determinant of health, which is the education level and the health literacy. So we run reports on a regular basis to see how our performance is doing. And also La Maestra performance measures, which speaks to us. It helps us help the providers to see how they can better the care that they're giving their patient in 15 minutes. Here is an example of La Maestra performance, the performance measures that we get from our population health management tool, where you are able to customize this to your needs per organization. We have customized it to us, and we have been able to set target goals that as soon as we meet those target goals, we're able to increase them. So one example here is diabetic patients. Now we have it at 65%. We want to have patients with hemoglobin A1C less than 7 at a 65%. We are working on that because we're not quite there yet. In order for us to be able to achieve this, we need to make sure that we have the correct data and that the data is that we trust what we're doing, and we do. So we have a plan. We have been able to implement within the food pantry, something that will help the patients. So we're able to help them with cooking classes, specializes for patients with diabetes. We give them recipes that are appropriate in their own language, and we're able to also give foods that are they're known to them so that they're able to cook it as well. All this done by only looking at the data and by using the circle of care of La Maestra. This is something that particular of our managed care plans love, which is our HEDIS measures, because we're able to work with our managed care plans in a very intimate way so that we can both achieve what we are looking for our patient, the best outcomes. How can we help each other? So this is the way that we help the managed care plans to accomplish their goals, and it's a constant feedback between La Maestra and the managed care plans. These daily searches that we run for population health management, because remember, this is something that happens every day and at any given moment. So we run these researches every day. We make sure that they are, they are preset and is done to make sure that if we have patients that are coming to us with diabetes or hypertension or that need depression screening, we're able to see which ones they are and immediately address the need of the patient at that given point. I love this huddle sheet. This is something that we have adopted at La Maestra, and this is something that we feel very, it has really helped our providers, and our providers talk very highly about this because it helps them see exactly what they need for that particular patient. If the patient has high blood pressure, if the patient has diabetes or hyperlipidemia, they see it right there at that moment, even if the patient is coming for a year follow-up or if it's coming for a follow-up or an urgent visit. So we're able to address that. But not only that, this tool also gives us the possibility to address another social determinant of health, which is the language barrier. If the patient speaks a different language than the provider will be able to see it right there. And our cultural liaison are able to know and plan their data ahead of time so that they can help as many patients as possible to understand their health issues and hopefully to better their outcomes from that particular visit. In addressing the language barrier, we have other ways that we use our population health management, and also this helps us to with the empowerment of our patients to our providers. Since I said that we speak many different languages and dialects here at La Maestra, we try to leverage that because even our providers speak 2 and 3 different languages. So we run reports and we see what languages are being spoken that particular day by the patients that are going to be seen by one particular provider. And we see if we're doing our job on trying to make sure that we empanel the patient to the right provider. As you guys can see on the right-hand side, we have a provider that I know for a fact, his first language is Arabic. So we're doing a good job on trying to make sure that we give Arabic-speaking patients to an Arabic-speaking provider. And the same thing with the graphic on the left. This is a graphic for a provider whose primary or secondary language is Spanish, and most of his patients have identified Spanish as the primary or preferred language to speak with. With the other languages that we see, it's not that we don't take priority, but at least we will see how can we better our empowerment for our patients. And also, we will see if we need a cultural liaison to be able to see this particular patient. Addressing more language barrier in the health literacy. This is very important. As we said here at La Maestra, and in fact La Maestra translates as the teacher in Spanish. So we're huge in education. It's very important for us that we educate our patients. So our population health management give us the possibility to do so. So we're able to create information for our patient in different languages to educate them and to help them understand, to hopefully overcome that particular barrier and get better outcomes. So there is health education on healthy behaviors. There is health education on hypertension, diabetes. And as you guys can see, we have it in different languages, Spanish, English, Arabic, and now we're working and keep translating all the material that we have in the languages that we need. Somali, Vietnamese, etc. This is an example of what we have and that we give to our patients. This is, we're able to print it directly from the population health management tool that we have. So we have Arabic, Spanish, and English at this point. So how do we keep ourselves self-sustainable? How do we know what else do we need? This is very important because our circle of care is growing. And how are we successful within the circle of care? Because we keep track. How do we keep track? We need to see what is the need of the population? Where do we have more needs? And for that, we use our internal referrals, and we run reports constantly just to see, okay, are our providers using or is our staff using the services? And maybe if we see one services that is being used constantly, we need to increase that particular service. As we can see, the dental services in La Maestra is something that is used constantly. And so because we've taken this data, we have been able to justify opening more sites to be able to serve more patients. The same thing with health education. So our health education department, this is an internal referral, and we are noticing that our patients need education. Our providers need the help of the health educator in order to overcome that lack of health literacy of our patients. And also because, as we know, with 50 minutes, our providers are not going to be able to communicate everything that needs to be communicated to our patients. So our health educator is another way that we are able to bridge that gap in education and hopefully just spend more time with the patient so the patient can understand what's going on with them. How do we address social determinants of health by a no-show rate? Well, we run constant reports, as you guys have seen up to now. We run in constant basis, and it's run by our patient care coordinator. Periodically, the no-show rate and the non-completed reports are run and addressed within the patients to identify the possible barriers. So once we realize that our patients are not showing, so we call them and we ask them and we investigate why aren't our patients showing. And something that we realized is that our pediatrics patients were not showing to their ENT appointments. And we started asking why. We realized that transportation was an issue, and also language was an issue. Our patients were afraid that nobody was going to speak their language, so they didn't want to go. So what we did is we were able to use technology to bridge the gap. We were able to connect our patients from our side to the specialist side, and we were able to reduce the no-show rate for that particular specialty from 50% to 13%. Other indicators that we use, that we address through the eye-to-eye system that we use are, as we see, all this, all what we need for screening, so mammo screening, pap screenings, so that we're able to reach the goal. So we create searches that are run periodically that we call patients. The goal is to increase compliance and screening and services. So hopefully that we are able to detect on time and that we eventually will reduce the amount of patients that are going undiagnosed. And something that is very important to us is a peer review. So we even use our population health management to keep track of our peer review. When do we do it and how do we do it? What patients have been reviewed, what providers have been reviewed. So we're also increasing the communication by text messages. This is a new feature that we have added within our population health management, and I particularly love it because we can do education, we can do outreach, we can do a lot of things with this particular feature right now. So this is an example of an education that we sent, or just, general outreach for our patients. What is very interesting, we have been using this for the last 3 months, and just last week I had a phone call due to a mistype of one of the text messages, but the phone call was, oh my gosh, what are you guys doing that is having our patients call and asking for mammograms? What are you guys doing? Well, we realized it was the text messages that we were sending and the letters that we were sending in order to inform our patients. And this is not a recall list. This is just outreaching and education and educating our patients. And we do this in also different languages. So our patients feel that they matter. Our patients feel that we care. So why to use population health management system to address social determinants of health? I mean, we could just see patients and that's it. But realistically, the population health management systems are designed for this particular purpose, to make sure that we're able to bridge gaps, to make sure that we're able to address those social determinants of health. And why should we address social determinants of health? Why shouldn't just we see patients and that's it? Well, because that's not quality care. We have to address social determinants of health to be able to achieve quality care, to better care for our patients. Because also we're moving from a value-based system from a volume-based system to a value-based system. So we are ready for the reform that is coming, because it is more cost-effective long-term, and because health and wellness are not mutually exclusive. They go hand in hand. To achieve a broader improvement in health and a greater health equity, that is very important. Thank you very much for your attention.
Thank you so much, Sonia. That was amazing presentation and just really great information. Before we take your questions, I want to personally invite you all to attend the 2016 I2I User Conference, Transforming Outcomes. This is really the perfect opportunity for you all to network with other users, hear from expert speakers, expand your I2I skills, and even take part in the hands-on computer lab training. Our conference this year will be held May 19th to 20th in Las Vegas, Nevada, and you can visit www.i2isys.com to find out more information and get registered. So with that, we're going to go ahead. We have several questions that have come in, so I just wanted to go through those with you all. One question that came in is for Sonia, and it says, are all of the graphs and reports generated from I2I tracks that you showed?
Yes, all of the graphs are generated from I2I tracks.
Great. I could have answered that for you, but I thought that was really designed for you. So the next question that came in was this. We have just now started to capture social determinants in our EHR. Can you suggest a few first steps to really integrate the social determinants into our care model? So they've just started, it sounds like they're just starting to capture the data. What should they take a look at first?
In my opinion, I would let Chris, if she's still on the phone, also to chime in. But definitely, one thing that for us, Liz, is very important, and it's just the language. Language is something that you always need to look into, because if your patient don't understand what the provider is saying, and by experience, our patients will say yes, 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 and realistically, they're not understanding what we're telling them. They just want to say yes because they're just afraid or scared that you're not going to be able to repeat, or the provider will get upset or whatnot. So I would say start with language.
Great. Chris, did you have anything to add to that?
I think that that is an excellent point. And, what I would also add is what is relevant in your community? What are the hospitals looking at? What are your public health programs telling you are the relevant issues and the prevalent things that are happening? What are payers looking at, and really trying to figure out what is going to be the intervention that targets the most patients or the people with the highest risk problems.
This next question is also for Sonia. Have you been able to address behavioral health issues using this model?
Yes, we have been. And we have been, and the reason why we know that, as you guys know, we have refugees as our patients. So we do have some behavioral and mental health issues that it could be unique to us. But using this model, we have been able to pinpoint where we needed to put more efforts into, and we have in fact brought 2 different initiatives in order to be able to do this.
Great. And then Sonia, this one sounds also like it's for you. How much time do you allow for each encounter as part of your empanelment process? And have you seen an increase in time required to address the social determinants of health issues?
So we do use a lot of our ancillary staff in order to address the social determinants of health because we have not changed yet the time for each encounter. So it varies, 15 to 30 minutes depending what they're coming for, but we try to do a lot of the work ahead of time. That's why I said our circle of care is known from all the way to the person that answers the phone and makes the appointment, all the way to the person that checks out the patient, so that we're ready for the day and for the provider, so that we're helping the provider just to focus on what is needed from them. We, the ancillary staff, will focus on the social determinants of health, and that we make sure that we tag and we inform the provider this is what the patient is needed. So we do a little bit of work ahead of time.
Great. And there's several questions about your medically trained cultural liaisons. First of all, how many do you have? Are they volunteers? What other work do they do? Can you tell us just a little bit more about their cultural liaisons?
So it varies. We have about 42 of them. They're not volunteers, they're paid staff. And something very, very unique about them is a lot of them, they do have medical train back in their countries. So they were either nurses or they worked into the medical communities back home. So they understand what we're talking about. It varies from site to site. In our main site, that's where we have the majority of our cultural liaison. They do a lot of the education. They're the patient. Most of them are patient coordinators. They don't only do translator. They also do education. In fact, most of my educators speak 2 and 3 different languages. And they just make sure that they make the patient feel comfortable and understood with, it's not only translating, it's also holding the hand of the patient to make sure that they understand what services we have. And there are also tasked with identifying what services are also needed. A lot of these people come exactly from the communities that we work on. So they know the need of the community and they know the people of the community as well.
Great. Thank you, Sonia. Here's one more question for you. How much time was spent into training staff on using social determinants of health to address the healthcare?
When the staff comes, well, by the way, this is a constant process that we have. We remind them. We have a training available every Wednesday from 9 to 2 o'clock in the afternoon. We have staff training, whoever feels they need small training. But as soon as you come on board to La Maestra, you go for a whole week learning every single step within La Maestra. What do we have? How does it work? How to refer? Who do you need to talk to? And if after that you still feel that you need more training, that goes all the way from the person that opens the door, all the way to the checkout staff, the provider, whoever needs more training and feels that needs more training, we're always available. And we have a mandatory training where we talk about social determinants of health and we address this issue 2 times per year. And it's mandatory.
Great. Excellent. Well, we are out of time, and I know that the questions are still coming in, but if we did not get a chance to answer your question, we will connect with you directly to do so. So on behalf of Chris and Sonia and all of us at I2I, I really want to thank you for taking the time out of your busy schedules to attend today's webinar. For more information on I2I solutions, you could visit our website at www.i2isys.com, or you could email us at info@i2isys.com. Thank you all for attending, and have a wonderful, wonderful day.